for having me. This is really fun and exciting and terrifying all at the same time. So I'm excited. So I didn't really prepare anything. There is no PowerPoint presentation because I think we've all seen enough PowerPoints in our lives. So I really just wanted this to be more informative and helpful, and anything that I can do. I am the first physician in my family. So I remember when I was like starting out, I had no idea what I was doing. I had no idea what an Mcat was. I had no idea what's like board exams and steps and all the process that's involved in going to medical school. I knew I just wanted to be a doctor, and I had to just figure out how to make that happen. So I would have loved to have something like this back when I was in college, which I'm going to pretend was like yesterday, but it was definitely a lot longer than that. So I guess I will just kind of share a little bit about me. I was actually born and raised in Montana and went to a state college. I went to a state college up there called Montana State. It was my major was cell biology and neuroscience. And then I realized very quickly that I wanted to be a little different. So I actually also added in, from Bozeman. So cold up there right now. It's so cold. I'm much happier in Las Vegas. But I also got a minor in English writing as well, which was really great. I actually got a lot of questions about that when I was interviewing for medical school, and it came in very handy just with conversations and writing. I know writing's no longer involved in any of your testing, but back in the day it was. So it was very helpful. But I liked it too because I wanted to show that I wasn't just science, that I had so many other facets to who I am. So that's what I majored in, was cell biology and neuroscience, and then English minor. I love it. And I applied to, so where I went, they were like, it was basically MD schools are best. So I was never really taught about DO schools. I was never taught about DO school options. I had no clue, and it was basically, they were like, if you don't get into this MD school, you're a failure. And I was like, well, I don't want to go to that MD school. That doesn't sound fun. And they look really miserable. So I don't want to do that. So I did my own research, and I just basically, when it came time to apply to medical schools, I made sure that I just picked off location, and then I learned slowly about DO schools. And for me, I was accepted to both MD and DO schools, but I ended up picking up DO medical school. One, because of location. I actually went to medical school here in Henderson, Nevada, which is like a suburb basically of Las Vegas. But everyone was nice. I mean, I really connected so much better with DO teachers, faculty, students when I was doing my interviews, that I said, okay, if I'm going to spend the next 4 years of my life basically with my head in a book, I at least want to enjoy it with the people that I'm with. So that's why I ended up ultimately picking a DO school to go to instead of an MD school. I'm here to tell you you can literally do anything as a DO. You can do exactly the same things that MDs do. And fast forward a couple years down the road, I ended up going to an MD residency. So you can really do anything you want with that. So just to back up a little bit, I don't know how many of you guys, oh my gosh, I don't know how many of you know my story. Probably none of you, because why would you? But I actually failed my first Mcat. My first Mcat score was like, God, I try to forget it. It's like PTSD. I feel like I try to forget it, but it was in the like 20. I don't know. It was bad. Basically, my guidance counselor told me that you should think of another profession. She told me, she said, I don't think that being a doctor is going to work for you. I don't think this is a good option for you. You didn't score well enough. You're not competitive anymore. So basically give up your dream. That was the kick in the pants that I needed. When I took my first Mcat, I didn't study. I just walked in there because I said, oh, I've got, a high GPA. I'm fine. I got this. And I didn't. Kicked me in the butt. So I spent the next year doing, refresher courses with different classes at my college level. And then I actually took a month off in the summer and studied like a full-time job. So 8 to 5 every day, Monday through Friday, I was at the library doing practice tests, doing questions, really trying to prove to myself that this dream was meant for me, and that even though no one else was a doctor, even though that my guidance counselor told me I couldn't do this, even though, I didn't meet the check boxes that you're supposed to meet, I was like, I'm going to do this. This is my dream. This is what I want to do. Screw the people that don't believe in me, basically is what I thought. And I raised my score to be very competitive, which was great. And I was very, very thankful for that. So I think that that's one of the things that I really want to make sure you guys just take away from this is if you have a dream and if you're here, do not let anyone tell you that you should not achieve that dream, and do not let anyone tell you that you shouldn't be whatever you want to be. That's my first focus for sure. So fast forward, I am going to medical school. I get into medical school. I have no idea what to expect. I moved to Las Vegas, and it's very, very, very overwhelming at first. People use the analogy, like when you start medical school, it's like drinking from a fire hose, and that is exactly what it's like. It's like, oh my gosh, this is so much information. This is crazy. I just saw someone about a non-traditional student. A lot of people in my medical school class were non-traditional students. So I always tell people, I go, age means nothing at all. If you want to do it, do it. Because at the end of the day, you're going to be 50, and do you want to be 50 and be a doctor, or do you want to be 50 and be something else? So I always say, whatever, just do it. Who cares if you're traditional or not? And what the heck does that even mean? So, sorry, I'm like squirrel. So anyways, I went to school, and my first semester was pretty rough, just trying to find a friend group to study with, trying to find how to study in medical school, because it's so different than undergrad. And so ultimately ended up finding a great study group. And that is what helped me probably the most, because having people that all actually also go to lectures, and that also, are there, they can pick up different information that you might not get right away. And so when we would do quizzing, I'd be like, oh my gosh, I didn't even hear the teacher say that, or that's such a good point. I didn't think that was the main point. So it's for me, study groups were huge. And having a person that you can quiz back and forth, having a person that a group of people that you go through lectures and quiz each other. It's fun because you're not alone. If you're going to be studying, it sucks to study alone. So that was a great thing for me. And then I actually went into medical school having no clue what I wanted to do. I was basically I was like, well, I want to be in medicine. I don't know what type of medicine. I know that I'm not a big fan of surgery because I don't like standing for hours on end. And then I was like, and I don't like the hours. So that's when I really started to focus on primary care. And so I am a family medicine physician, and that's what I'm trained in. And ultimately it was after my rotation at the end of my third year with an outpatient family med doc who he knew his patients. He took care of his patients. It was just amazing. And he was here in Las Vegas. And that is what inspired me to pursue family medicine, because one, I was like, okay, lifestyle at the end of the day, someday I'm guessing I'll probably have kids. I have 2 dogs now, and that's plenty, but I can be home at a decent hour. I can go on vacation. I can see my family. I mean, I can do so many things that are important to me and have a life outside of being a physician. So ultimately I went with family medicine, also because I love my relationships with my patients. I think that's the best thing. They remember so many things about you that you don't remember you ever told them. But it's awesome. I mean, it's so cool to be a part of people's life. So I ended up doing several audition rotations at the residencies that I was interested in. Now, that's not always required in family medicine, but for me, I was really dead set on actually going back to Montana. I went to Billings, Montana for my residency. It's a very amazing residency that's associated with the University of Washington. So very excellent training, that full spectrum, old school family med doc. So deliver babies and all of that. And that was fantastic. I ended up doing an audition rotation there, and I matched during the match. If that makes, these are so many terms you learn down the road, but I got in there for residency, and I spent the next 3 years back in Billings, Montana, doing my residency. I worked at a community health center, and for people who are not familiar with Billings, it's about a town of 100,000 people, and it is I worked at a community health center that was heavily populated with people who were homeless, underserved, people who had a lot of adverse childhood experiences, a lot of mental health, a lot of drug abuse as well too. So it was just everything that you could think of. It was crazy, but I learned so much. And then I realized that I hated the snow. And so my husband and I moved back to Las Vegas because of a job here. And I ended up, I'm at my job that I started the day after I left residency. And I've been here now for I've been there for 3 years now. And the reason I picked the job that I picked is I loved the people that worked there. I mean, when I sat down to interview, it was like sitting at a family dinner. It was so great. And I didn't think that I was going to work with the older population. I thought I was going to be more of like your traditional family medicine, which is like your 30s, 40s, 50s, and some of your older people. But I had no clue that I was going to specialize in some, people over 65. I'm not geriatric trained or anything like that. So it's definitely a big learning curve for me to learn when I first started, but I love it. They're awesome. They're like so much fun. I was really thankful to find this job. It's outpatient. And then there was actually the option for partnership, which a lot of times doesn't exist in this day and age. So I ended up starting 3 years ago, and I'm the first and only female physician there. There's 2 other male physicians, and I'm about 15 years younger than any other provider. But it's so great. And I started as a partner, 5 months ago, 6 months ago. Yeah. So I am first female physician, first female partner. It's great to have a seat at the table. It's a little intimidating at times for sure, but it's been a huge, huge, huge blessing for me and a big learning curve. But also I think as females, we can bring so much more to the table that men might not think of, and vice versa, because, like men are from Mars, women are from Venus. We're just like different people. So it's been great. I love the 2 doctors that I work with. We talk about sports all day. I love sports. So it's fun. We laugh, and I get to, the nice part too, is that a lot of times in medicine, you are limited in the amount of time that you get with your patients. But this office has structured it to where you get 30 minutes per patient visit, and I see a max of 16 people a day. I work Monday through Friday, 7 to 4, and then on Friday we start at 8, and we work till 4:30, but have a longer lunch. It's weird. But yeah, it's been a wonderful, there's highs and lows with everything that you do, and you have to, I don't know, I'm a firm believer, how many years are we trained in hard sciences, but I'm a firm believer that you have got to, if it's going to happen, like there's an aspect of fate. I really, truly think that there were highs and lows throughout every single journey. Residency was brutal, and medical school was tough. But if you believe in yourself, and if that's where you want to go, and that's where your dream is at, it will happen. Like I'm a firm believer in that. People can call me crazy. It's totally fine. But that is just what I believe. So, yeah, I think that's my little intro. It feels like it took longer than 16 minutes to say, but I guess not.
Thank you so much for introducing yourself and talking to us about your experiences. There were a lot of questions already, so we'll get through some of them.
Okay.
I think one of the common questions that people had towards the beginning was, because you mentioned when you got a whole different study technique and you had to really get in the groove, and people are wondering what techniques really worked for you and what you found was so different from undergrad that made it a challenge.
Yeah. So I was always very much this person that could like read something and memorize it, and then memorize it well enough to take a test and pick the multiple choice answer. So I got very lazy with my studying, I guess you could say, in undergrad, because it's not as much material. So when I started in medical school, it was just too much information to try and memorize. I actually needed to learn it. And so that is where having the group study sessions. So we would go through PowerPoint. So like, let's say for physiology, we would start with the first lecture that was going to be on that test, and we wouldn't stop until we got to the last lecture on that test. And each person, there was 4 people in our group, each person would take a lecture and would go through it and would like kind of come up with test questions to ask the group. And we talk through problems, and we talk through scenarios, and we create, different lists or different groupings or different ways that you can remember everything. So that was a huge thing for me. So I went from just basically like passively reading and passively trying to memorize PowerPoint lectures to really truly understanding a lecture, because in order to quiz someone else, you have to know the material yourself. So it forced me to learn the material, and then vice versa. So I think that was probably the biggest change that happened, because I didn't say this, and I feel like I feel so crazy. I actually got like my worst grade ever when my first semester of medical school, and I was in the bottom 50% of my class. And then I switched and joined this group studying. Apparently I like to fail things first, and then I finally like learn what I'm supposed to do. So then I learned how to study. And then I ended up finishing my medical school in the top 10% of my class.
That's awesome. Thank you so much for sharing that.
Yeah,
I think a lot of us, I know I definitely struggled with the transition from even high school to undergrad was difficult. So I can't even imagine.
yeah, it
Um,
is. And that's, yeah, it's so hard. It's like, and no one really tells you how to do it. And sometimes it's such a trial and error that you're just like, what the heck am I supposed to do? So if you feel that way, it's normal, because I totally felt that way.
well, that's comforting. So thank you for that. Kind of going off of the studying topic, someone asked what you did differently to study for your MCAT the second time around. I think you mentioned that you didn't even study for.
I was
So
gonna say, I
how?
actually studied. That's where it's like I got a false sense of security. So I, my GPA was like 3.8 or 3.9 in undergrad. And so I was like, oh, let's just waltz right in there and take this test. And then I realized quickly that was not the way to do it. So I actually just did practice questions and did a lot of review books. I didn't do any specific, I know there's a lot of review courses out there. I like that you can pay thousands of dollars for. I didn't do that. I have had friends that have did that and they did well on their MCATs. And so I think it's whatever works for you. So for me, it was just actually sitting down, treating it like a job, cell phone away. Back then, Instagram didn't exist. So I think that was easier. But putting your phone away and just like literally, I locked myself in a library in the summer for the month of July.
Yeah, that's really impressive, as I'm also struggling. So I understand that it's difficult to study for that.
Yeah.
But thank you for that tip.
It's so hard. I did practice questions, and then what was so nice, like because then you can go through like the practice question answers. And I remember that actually some of my practice questions were on my test. So I was like, well, this is awesome. So just a little, I don't know if that still is the case, but that's what happened I remember that like vividly for some reason.
Yeah, thank you for that. A lot of people are saying they're going to make sure to do that.
Yeah.
There was some questions about your practice and about if there's, or what is your favorite part about working with, geriatric patients, and, what that's like, because I don't think a lot of people get to hear about that as much.
Oh my God, they're so fun. So first of all, most people that are over the age of 65 have started to have a little bit of frontal lobe atrophy, which is hilarious. So I probably get hit on by 80-year-old men more days than that, but they're so cute. They're so sweet. And they're like, tell your husband he's a lucky guy. And I was like, I will. So it's so fun. It's nice because I am so big on diet, exercise, preventative medicine. And a lot of times these people have lived for 60 years, 50 years, no one telling them that, hey, if you fix your diet, we can get you off these pills, or hey, if you move your body, like you're going to feel better. We can get so I'm a huge, huge, huge fan of preventative medicine. I probably spend a lot of time ad nauseum talking about it. So my patients are very aware of that, but it's fun. I mean, they love you so much. Like I bought a house a year ago. My patients are I don't even remember I told people I bought a house, and they'll see me back for a follow-up, and they're like, so how's your house? Like, how are things going? Like, they don't care about their diabetes. I care about their diabetes. They want to know how my house is going, or how my husband is, or how my dogs are. And I'm like, I don't even remember telling you this, but it's cool because they truly, truly, truly need you, but they also enjoy you. And it becomes especially like during COVID, a lot of our patients didn't leave their house, but they wanted to come to a doctor's visit because it was like social, and they needed that interaction for whether it was like worsening depression or anxiety, or just someone to like tell them it's all going to be okay, and that became a huge thing where you didn't realize how much they relied on just, I don't know, positive thoughts, social interaction. I think we've all probably realized that, but yeah, I think, and then you have to, obviously with people that are over 65, you have to be aware. I'll go into like the science part of it since it's not all just social. You have to be aware of medications, so dosages that they're taking. And in Vegas, there's a huge problem with like benzos and all of these medications and opiates. So you have to make sure that you do a lot of education, and that a lot of patients over 65 will have side effects from medication. So that's why I really try and avoid most medications in my patients, because then you end up dealing with side effects from a medication. So you give them another medication for the side effects, and then it just spirals out of control. And that's how some people end up with med lists this long.
Yeah, for sure. So thank you for that. Loved hearing that. Since you mentioned COVID, a lot of people are asking, how exactly has the pandemic affected the practice?
So when COVID first hit, we went from being so busy, like full schedules, jam-packed, working after hours, to one day I saw 4 people in a whole day. And so, you know, you forget. So I don't work for a big corporation. That was one of the biggest things that I wanted to not do when I got out of residency, because I just felt like it was a glorified residency to me. And I wanted to have some autonomy with my career. If I needed to take a day off, if I needed to, you know, do something, it wasn't like, oh, well, you're going to have to use this PTO. You don't have any more days. You know, it didn't feel right for me. So I really wanted to work for a small business, but there are risks when you do that. And it was very evident during COVID. So in order to not, as a business, you know, at the end of the day, medicine is a business as well. And we have to keep our doors open and keep people paid and, you know, make sure that we're paid, because my student loan payments sure as heck didn't stop. So we actually, as providers, all took a 20% pay cut. By doing that, we were able to not have to furlough anyone at the practice, which is great, medical assistants included. And it was just a decision that we all made. And it stayed that way for about 7 months. And then when did COVID really started, like March here in Vegas. So by April, we were fully telemedicine, and we did full telemedicine for about 4 or 5 months. And then patients actually started to refuse it. And that is definitely their choice, you know. So patients really wanted to come in because they'd just been sick of being locked up, and they hadn't seen their grandkids, or they hadn't seen their kids, or they hadn't seen their neighbors, and they just wanted to talk to people. So now I probably maybe only do like 1 or 2 telemedicine visits, and the rest of my visits are with my patients. They've got a mask and I've got a mask. So.
Great. Thank you for talking about that. We've heard a lot about how COVID has affected different practices. So thank you for your perspective. Kind of on the topic of your practice as well, when you were talking about partnership, a lot of people were wondering like what exactly that is and what the difference is like between being a partner, not being a partner, and why you said that it's kind of outdated now.
So the reason is that there's not a lot of private practices that still exist in this day and age. A lot of places are hospital owned or are owned by bigger corporations like insurance companies. And so as a partner, I'm actually a part owner. So I own 20% of the entire practice. And for me, it's job security. For me, it's a seat at the table. And for me, it was also like my future as well too. And it's like one of those things where I was like, I want to be able to grow this. I want to be able to, you know, retire from this place. This is like where I want to, I don't really want to go work anywhere else. I'm really happy with where I'm at. So I think I just want to make this like work for everybody. And so you have to take a pay cut. Like I'm just talking about pay cuts. You have to take a pay cut when you start becoming a partner, because you have to buy in. So, right, I wasn't just gifted 20% of the company. I had to buy my share of the company. So I'm doing it over 5 years. The nice part is that because my practice is small, you usually have to like work up to 20% over 5 years. So I'm really bad at math. You guys are going to learn. I don't even know what you would get every year, but my practice is like right away you get 20%. So then that way, if there is a profit at the end of the day, the 3 partners will split it, and I would get 20% of that. So for me, it was a great way to also financially secure myself, but also, like I said, give myself a seat at the table. There's a lot of decisions that are made behind the scenes that you don't realize, from the finances to the contracts to everything else. And it's great to be a part of it, because if not, you're an employee and you get told what to do and you get told how you should do it. Whereas to be a partner, there's a lot more autonomy and independence for sure.
That's awesome. Someone said they're an accountant in the chat, so there was some math going on. So that was fine.
My mom's a CPA. She's my CPA actually.
That's so awesome.
I'm sure they know way more than me. Oh my God.
Yeah, there was some little math going on in the chat.
Yeah, so I'm glad someone knows math. I'm like so bad at it, but I just got automatically 20% right away. And I know that doesn't happen normally, so.
We had a really good question from someone. They asked if you could do kind of a simplified day at work, and what are some of the most common cases that you get, especially with your geriatric population?
Yeah, totally. So most of my people that I see, diabetes is very common. High blood pressure is really common. Arthritis is very common. Back pain can be common too. Even like peripheral neuropathy, and then a lot of times even unsteadiness too. And then depression, that's a very, very common thing that people don't think about in the geriatric population. They think it's like more a young person's problem, but it's really not, you know, especially when these people who've been married to someone for 50 years and they die, it's, oh, it pulls at your heart. So yeah, so like a normal day, I start at 7, my first patient's at 7. If it's a new patient, our office actually does all of our new patients on paper. So we just sit down with a piece of paper and we write out a little soap note, and there's no computer, which a lot of the patients love because they're like, no one's actually asked me these questions. No one's sat down and ever done this with me before. So we don't give them a form to fill out of their past medical history. I go through and ask that, which is a little time consuming, but then I remember the patient better. They feel like they have better rapport with me and it just really works out well. So there's those, so new patient visits, then there's follow-up visits. Usually follow-up visits are usually, you know, like an A1C and maybe kidney function. Oh, another thing we deal with a lot is chronic kidney disease, very common in patients over 65. So it's another thing that we're always watching. And usually it's just, I usually do labs every 3 to 4 months for my chronic diabetics or my chronic kidney disease people. So we're just usually following up on that. And then for Medicare, because we deal with a lot of Medicare patients, there's Medicare annuals is what they're called. And so it's a big wellness annual. And that's when you do like 3 pages of lab work. You basically do everything. And you look at their preventative medicine and see, you know, when their last colonoscopy was, when their last mammogram was, when their last bone density scan was, PSA, all of those things, and kind of do a full visit. So that's when you do the med rec, take a look at what meds are you taking, what meds are you not taking, how are you doing with these? So those are long visits. Usually too, we also do EKGs at our office. So if they've got high blood pressure, diabetes, any risk, tobacco abuse, any risk factors for some type of heart disease, we will always do an EKG as a screening. And then I'm trying to think what else. We do pre-op stuff, but yeah, it's basically kind of, you're just rolling throughout the day. Every now and then you'll get an acute. It doesn't happen as often to me as it does we've got a nurse practitioner and a physician assistant as well. So they do more of our acute care. But every now and then you'll get an acute, like in Vegas. Oh my God, Vegas is the land of allergies. So everyone here has sinus problems and allergies. I thought they were all just joking. When I moved here, I was like, okay, this many people cannot have allergies. Like, you guys all got to settle down. Everyone has allergies here. Everybody, literally everyone. So it's brutal. So I deal with a lot of sinus stuff a lot too. That's just Vegas, but it's yeah, that's kind of a summary of it, I guess. I hope that was helpful. I think I rambled.
Yeah, we're laughing right now because Lana is suffering through the allergies. So
I remember when I first came, I was like, you guys, come on, you do not have allergies. You're 76, you're fine.
Yeah, we're in Texas, so we feel
yeah.
that.
Oh my gosh. Yeah.
Yeah, so sorry, that's so funny. There was you talked about medications and how in Las Vegas specifically, you know, there's some issues there. How do you deal with, you know, or do you really get to experience that requesting certain medications and confronting the issue and having to just kind of have that uncomfortable conversation where you know something's a little fishy?
Yeah, so we have a lot. I mean, at the end of the day, there are a lot of older people that are on chronic, you know, opiate pain medications, whether they can't have knee replacements, you know, whether they are not, you know, they failed back surgery or, you know, whatever it might be. And so there's definitely steps that we have to take. So it's like printing, you know, an agreement. They understand what they're doing. They understand the drug that they're taking, the side effects from it. I'm very blunt about it. Probably maybe sometimes to a fault, but sometimes I'll tell people, I'll be like, I'm basically prescribing you like heroin. I just need you to know and understand what you're doing here and what we're taking and the addiction and the fact that when you take it with your Xanax, it can kill you, just so you know. And then people are like, oh, no one's ever like told me that. And I don't know, probably is a little bit too blunt. I don't know. You guys can totally judge me if you need to, but I think that it really gets the point across because people don't really talk about what's in this medication, what's in this drug, what are the side effects from it? You know, people are like, oh, you need a pain med, here you go. You know, because a lot of times I think physicians get burnt out and I think physicians don't want to have the conversation. It's a heck of a lot easier to write a prescription than to have a conversation like, hey, let's get you off this. Like, for example, I have a lady on tramadol. She is 70. She's 70. Yeah. She's obese, morbidly obese, and she had wildly uncontrolled diabetes. I had been trying to control it for a year. It was a year of me like saying, could you just eat some leafy greens and stop eating potatoes? Like, that is what I was talking about for a year. And finally I said, okay, miss, I can't say her name because of HIPAA. I said, miss, I cannot continue to give you tramadol and I cannot continue to do these things for you if you do not help yourself. Because I am not going to be the person that's just going to be supplying you with medications if you're not exercising, if you're not losing weight, if you're not actually trying to control your diabetes. And she dropped her A1C from 10.8 to 7.2 in 3 months, all because she wanted Tramadol. But whatever their motivating factor is, whatever it might be, she also lost 20 pounds and feels better. So it was, I don't know, I'm call me a little bit non-traditional with it, but sometimes you kind of have to light a spark under people's butts, and sometimes it's their pain medication, unfortunately. So that was something recently where I had to deal with that conversation of like, okay, I'm okay with you being on this chronic opioid, but I need you to make sure you're also exercising and you're doing all of these other things so that it's not just us putting a Band-Aid on it.
Yeah, that's great that it worked, but yeah, it's
hard though. There are fail stories too. Trust me, guys. It is not, I don't have just success stories. It is a lot. Sometimes people say, I've had a patient actually refuse to never see me again because I lowered her opiate dose. So it's one of those things where people get very emotionally tied to it. So it can be a very tricky subject. And sometimes I don't do the best of walking on eggshells like I should around people. And they get very emotionally attached to their medications, and it can result in they just refuse to see you. So that has happened too. So I just want to just stay real, keep it real.
Thank you for that. The kind of shifting gears a little bit, there was some questions earlier on, and again, asking if you ever had dealt with burnout, both in medical school, residency, and practicing as a family medicine physician.
Yeah. Oh my God. I think everyone's dealt with burnout. And if they tell you that they haven't, they're lying. It is brutal. I dealt with burnout actually during residency. Residency was very emotionally, mentally, pretty toxic for me. It was a great learning experience, but I also learned that if you speak out, at least at my specific program, if you speak out or if you have an opinion that's different than the program director, I was labeled reactive and non-compliant and all of these things that ended up happening. And my program director was male. I don't know, I'm not going to go like the male female thing because I really don't think that was it. I think it was more just me saying something that he didn't agree with and saying it loud. And what happened then was burnout, and it was horrible, and there's not a lot of programs that are equipped to help residents with burnout. And so it was actually one of my co-residents who I became very close with. And then, I was lucky enough that I did do residency where my parents both live. So it was very nice to be able to go home and just like have my parents cook me dinner, or there was something about that was very, very comforting. But I also stopped exercising for a while too. And for me, exercise is one of the most important things in my life that I do, not only to stay healthy physically, but also mentally. And so I figured out, I did 30-minute home videos because I was in residency. So you're making like $6 an hour. So I couldn't afford to go to a gym. So I ended up, and my husband was actually going back to school. He just finished his doctorate in physical therapy. So my husband was going back to school. So we were both just poor students together in our 30s. Like, what the heck? How did this happen? But I ended up doing like Jillian Michaels 30-minute workout videos at home. Felt really cool. My dogs were like, what are you doing? But that for me was such a great relief. I was like, I have 30 minutes. I have 30 minutes to dedicate to myself. I have 30 minutes, 4 days a week to make myself sweat, to make myself feel short of breath, to make myself feel like I'm having a heart attack, because emotionally it's going to be so much better for me. So I ended up just doing a lot of that workouts at home, and it was very, very helpful. But then also talking, I was very open about it with my husband, very open about it with my parents, and then my one friend, my one close friend in residency too. So
thank you for sharing your experiences and really motivating us. A lot of people in the chat were sad for you, but also happy that it worked out.
Yeah. Oh my God. I think it always works out too. It's like, I'm such a, oh my God, the funniest story. I'm such a positive mindset person. Like, I'm like, oh, if you're just positive, like it's going to work out. And I told a patient that the other day, and she was like, I do not believe in that stuff. I was like, okay.
That's awesome. That's so funny. We had a question asking about how often you use OMM practice, if at all, since that is something that's specific to like the DO profession. And so if you could talk about that and like your views on it.
So I don't use it at all in my practice that I do now. I did use it in residency a lot, and it was nice because our residency was an MD residency, but then they became duly accredited my third year. So they had both MD and DO accreditation, which was awesome. And so we got to do some OMT clinics my third year, which was great for boards, obviously, but then also great for the patients. They loved it. So I wish I did more. It's very hard to incorporate into your practice, but it's a great skill to have to help your loved ones. But there are some people who do just OMT clinics, and I freaking love those people. Those people are amazing, and I think they're the most talented people in the world, and I refer all my patients there because I'm like, go there, physical therapy, like this will help. So I'm a big fan of it. We just don't do a lot of it, unfortunately, in our practice.
Great. Thanks for sharing, because a lot of the DOs that we had talked a lot about OMM. So it's nice to see that other perspective of like, if you don't like it, you don't really have to use it.
No, oh my gosh. And a ton of my friends who I went to medical school with, they don't do it either. So, Speaking of which, I feel like I just need to say this. One of my friends, he is a DO, he's a general surgeon. He was the first DO accepted into an MD program, surgery residency in Denver. So you can do anything as a DO, just so you guys know.
That's awesome. Yeah, someone just said that you actually have made them consider DO school. So thanks.
We're like really nice and personable and like fun.
I think a lot of the questions kind of like when you were talking about burnout and stuff, and we touched on this a little before the session, but kind of like that word balance and what that means to you. And we know you kind of like talking about that and your perspective. So if you could touch on that.
Yeah, so I don't believe in balance. I think it's a whole bunch of BS. I think that it's a whole bunch of BS that sets us up for failure, because who the hell can balance everything? Like what? There's no way. I'd need 17 arms. It doesn't exist. So I have always preached being present. So like right now, I am present here in this moment. My phone is going off, but I really don't care, because I'm present here. And when I am done with this, I will take 20 minutes and I will dedicate it to social media. And then I'm going to have dinner with my husband and play with my dogs and dedicate time to that. And so I think the biggest thing is having balance. So literally, when you are present, whether it's in clinic, whether it's studying, whether it's with friends, I mean, be present and be there and give it your whole energy and your whole thought process. Put your phone on airplane mode. You don't need it. You're going to survive if you don't have your phone for 2 hours. It's going to be fine. Like I went to my friend's birthday. If you're on call, don't put your phone on airplane mode. But I went to my friend's birthday and I put my phone on airplane mode because I said, I don't even want it to like go off. No one's going to need me for 3 hours. It's going to be okay. The world will keep spinning. So I don't believe in balance. I believe in being present, and I believe in giving every single thing that you're doing, every single hat you're wearing, whatever it is, whether it's student, mom, dad, wife, husband, boyfriend, girlfriend, I don't know, whatever you want, whatever roles you've got, it's just being present at that moment. So like the worst thing I used to do is I used to sit with my husband on my phone, and I was like, this isn't quality time for anybody. This isn't good for anybody. So when I'm with my husband, I'm with my husband. When I'm with doing whatever social media stuff, or I have businesses that I'm doing, like then I do that. So it's just a matter of being there. I think that's the biggest thing. And don't try to balance it all, because it's going to drive you nuts, and it can lead to actually more burnout. If you're like, I'm not balancing all of these things. Nobody is. It's a newsflash. No one's balancing anything. We're all just existing and trying to survive. I think that's the biggest thing.
Yeah, that's always a good reminder for sure. We all need to hear it a lot.
Yeah, we do. I have to tell myself that too. I tell myself I'm a recovering perfectionist too.
Yeah, Lana and I are both psych majors, so we definitely know that we know what to do and we still don't do it, but
oh my God, right? Yeah.
But yeah, for sure, it's actually been proven, everyone, in case you wanted to know, that especially during the pandemic, they've done studies that multitasking does not work. You do not get anything done.
Yeah, we suck at multitasking.
Yeah, we're awful at it, so I don't know why we always assume that we can, but here we are. There was a question and I lost it thinking about it. Okay, there it is. Could you explain your experience with applying to an MD residency coming from a DO medical school?
Mm-hmm. It was basically exactly the same as any of my MD counterparts. It was It was super easy. You just have to use a different platform. So there's two electronic, I don't know if they've integrated it. There was talks, I have no clue. I'm a little out of date, clearly. But there's two platforms that you apply through. And so I just applied through the MD program for the MD match and was ranked and was accepted. So there was nothing new. It wasn't hard at all. I was never shunned for being a DO. I never felt less competitive for being a DO. I never felt anything compared to being a DO. In fact, sometimes people actually appreciate it. And I actually work at an office where there's only DOs. All the physicians are 3 DOs. There's no MDs at our practice. And we have patients who come in or patients that request to only see DO physicians. So I think it's definitely a profession that people are realizing, oh, hey, especially in primary care, I kind of want to be able to talk to my family doctor or my internal medicine doctor or whatever it is. But I was competitive the entire way through my residency application process for the various MD residencies that I interviewed at.
Yeah, for sure. We actually had someone earlier say that they actually seek out DOs. So you have at least one here. Yes. We did have some questions earlier just asking, really like if you could specifically say why family medicine and why not others. I know you talked about, the surgeries and some other specialties, but if there was anything else you wanted to ever do or consider, if you could talk about that.
Honestly, for me, family medicine was I just found it to be my niche. I was like, I love talking with people. I love creating relationships with people. I love changing someone's life from the ground up, not just cutting on them and maybe helping their back or whatever it might be, or putting a new knee in, or, giving them eye surgery or whatever it is. I wanted to actually be there long term. So I didn't want to just be someone that was in and out. I wanted to have a relationship with my patients. I wanted to affect change in their life. I wanted to get to know their kids, their grandkids. For instance, I have a patient, she started seeing me 2 years ago, and now she has referred her entire family, and I see her entire family, from her daughters to her grandkids to her husband and everything in between. And for me, that was a very cool part of medicine, because medicine is tough. Medicine is brutal. You are going to be getting beaten up sometimes, emotionally, mentally, all those things. Your paperwork's piling up and people are asking you all these things you need to do. And so having that, for me personally, being able to have great relationships with my patients was a big priority and helps me keep very balanced and even keeled, for sure. So I did my rotations in medical school, and I didn't pressure myself to make a decision early on onto what profession I had to go into. What's my specialty? Some people are they knew the day they started medical school what they were going to do. That's amazing. I was not one of those people. But congrats, good luck. That's amazing. Some people are I'm going to be a dermatologist. I'm going to be a vascular surgeon. And I was like, okay, awesome. I don't know what I'm going to do. So I just went into every single rotation with open eyes, open mind. And I was like, I don't like this. I like this. Can I see myself doing this for years, through the good times, through the bad times? And for me, family medicine came back as the winner every time.
Great. Thank you so much for that. There was a question earlier. Even though you're all about positivity and your positive mindset, people wanted to know, what are some downsides to your job?
The paperwork. The paperwork is a lot. It's a lot. It makes you want to pull your hair out at times. The paperwork's a lot. The documentation is tough. So I think it's more the mundane tasks of it all. Electronic medical records do not make anyone's life easier. So I'm just going to throw that out there. So that's probably the worst part of my job, is just the documentation and all the behind the scenes stuff, and battling insurances to get medications approved, like metformin. Yeah, it's ridiculous. So that's probably a tough part too, is insurance battling.
Thanks. I worked as a scribe, so I definitely know that EMRs suck, and I hate them. Yeah, Meditech is the worst. Someone was asking if, this is an interesting question. They asked if you can explain the difference between internal medicine and family medicine. I think some people have confusion with that in the chat. So the main differences, I guess.
Yeah, so family medicine is trained from birth to death, and internal medicine can only see 18 and over.
Awesome.
Sorry,
Thank you.
my
That
alarm
was
was going off.
that was simple.
Yeah, super easy. Family medicine can just see kids. So my residency, I delivered babies, and then I also, you know, like, so it was cool because I did prenatal care too in my residency. So we delivered babies and then took care of mom, took care of baby, and then I did all the well child checks with baby, and then I did all the follow-ups with mom. It was so fun, so much fun. So as an internal medicine doctor, it's just 18 and over, and no obstetrics, so no OB.
It's really cool that you can see people like of all ages and the whole family. That's awesome. There was people asking what, like in terms of your practice in particular, if you have PAs, NPs, and kind of those mid-level providers, and what their care looks like in your practice.
Yeah, we have got one PA and one nurse practitioner, and they see a lot of the kind of similar stuff that I do, but they see more acute visits as well too. So their schedule is not as filled with chronic patients and chronic follow-up patients. So they see some acute stuff too. So the nice part about our practice is that we tell people that if you're established that there's always same day or next day appointments available. If you have an acute issue that comes up, whether it's like, you know, rash or, you know, whatever it might be, cough, I don't know, scary to have a cough in this day and age, but the PA and the nurse practitioner are the ones who see the majority of those patients.
Oh, okay. Sorry, I thought we were all frozen. Okay. So thank you for that distinction, because I know it gets really confusing even for us, even though we've had an
They
answer
do a lot of the same stuff. They do a lot of the same stuff that I do. I mean, I just sign off on their EKGs is like probably the only difference. I don't have to have anyone sign off on my EKGs for my patients, but I sign off on theirs, and that's like about it.
Yeah, completely.
They're so like independent and autonomous. Like they're such rock stars. I love them both.
Yeah, thank you. So someone wanted to ask your opinion about where you think the future of small practice is going, especially, you know, with large hospitals and insurance companies kind of taking over.
I think it's so dependent on where you're at. Oh my gosh, I feel like every city is so different. I only have experience with 2 cities, so I don't know how good of an answer this is going to be. Vegas, people want it. People are sick of these big corporations. People are sick of these big like hospitals. In Billings, it's definitely more the small private practices are getting bought up by the hospitals. So that's definitely happening a little bit more in Billings, but it's obviously a much smaller scale. But in Vegas, people want private practices, and you can become affiliated with insurance companies. So there's a lot of business tactics that you can do to make sure that your private practice stays thriving.
Great, thank you so much. So I think you kind of mentioned this a little bit, but do you encourage your patients to make lifestyle nutritional changes in their life before or along with medications?
I will always try to have my patients make diet and lifestyle modifications before we add any medications on. I'm a firm believer in like, okay, your cholesterol is elevated. Maybe we should stop eating steak every night for dinner. Maybe we should, I don't know, eat some fish. Let's get crazy, some veggies, like go for a walk afterward or after dinner. So I totally just talk about that way more than being like, here's a cholesterol pill because you suck. Like, I just don't believe in that mentality, because then they get defeated and then they're not going to change anything. And then 10 years down the road, they've had a heart attack, they're morbidly obese, and they have no idea what the heck a vegetable is. So I try and intervene before all that happens. So I do a lot of lifestyle modifications first. And then if that doesn't work, then we have to do medications.
Great, thank you. This is also another opinion question, so now we're kind of like picking a brain. Someone asked, or someone I guess heard that if people apply to both MD and DO schools, it kind of shows that they're like not decided. And so what are your opinions on that? And do you think that it's totally fine to just apply to all of them?
I think that's like total bogus. I don't know who told you that or who told them that, sorry. But I think that's total bogus. Like, I applied to MD and DO schools and got accepted to both. You're fine. Like, you can do whatever you want, and no one thinks that you're not serious about one. At the end of the day, they both will do the same thing. So it's just a matter of, do you want to have additional education or not? So yeah, you can, yeah, you're good.
Great, thank you for that. I think that was asked like 2 or 3 times, so that's good to know that it's not really looked down upon.
And as a DO, I did a ton of research. So I've been published a couple of times too. I just to throw that out there, I presented at a national conference up in Canada. I actually built a shoulder model and was accepted to present at the American Academy of Sports Medicine, which is like a classically MD ortho conference. And so I did 2 research projects in residency and was as a DO and was completely accepted into national places to present without any issue at all.
That's awesome. There were some questions about research, so that's good to know. Another like opinion question is, why do you think that there's such a great need for not only family medicine, just primary care in general? Why that's like such a big gap in today's world?
I think it's because I really have no idea. I guess maybe just because the population's growing and maybe not everyone wants to go into primary care. I don't know. Our graduating school class from medical school actually had about 40% go into primary care, whether it was, and primary care is considered pediatrics, primary family medicine, internal medicine, OB. I think that's it. So it's considered, all of those are considered primary care. So I think that, I don't know. I don't know that answer, honestly. Primary care is getting reimbursed very well. So you can be very competitive and you can actually do a lot of fun things as a primary care physician. Like you're not just like locked into doing one thing. So there's a lot of opportunity to expand both, you know, your career and then financially as well too in primary care.
Great. Thank you for answering that and sharing that. So I guess we will do 2 more questions.
That works.
Perfect. Okay, so first of all, wait, where was it? Okay, so the chat's blowing up. So how do you deal with having, you know, the difficult conversation like end of life and, you know, because you do have older patients and ultimately you're not going to have too much time with them, unfortunately. Is that something that you have to talk to the families about, or, you know, kind of get accepted as well?
Yeah, it's definitely, those are tough conversations to have. And I always really try to approach it from a quality of life perspective and not a quantity of life perspective, and really trying to get the goals from the patient about what they want. Like if you got pneumonia, do you want to go to the hospital and get IVs and poked and all these things, or do you want to just not? You know, what are you, because you'll have patients who will come in and say, I'm done, you know, and they make that decision, but they don't know where to go or what to do. So those conversations are a little bit easier. A lot of times when patients are, you know, going into the hospital a lot, it's like in-stage COPD, which I forgot, I see a lot of COPD, in-stage COPD, where it's like all of these hospitalizations, you know, I really try and pull up like, okay, where are we at? You're on the max number of inhalers. You're on the highest level of oxygen. You've been in the hospital 6 times. You know, like what's our quality of life here? Where are we going? And what do you want? And some people aren't ready for hospice, and that's fine. Or some people aren't ready for palliative care, and that's fine. But at least having that conversation at least puts something in their brain as there is options and there is a way to have end of life with dignity and not be in a hospital bed, you know, hooked up to all the wires, which I think is so sad.
Great, thank you for sharing that. I guess we will end on this last question. As we are, you know, pre-med students and post-bac and masters and all of that fun stuff, in the heart of the pandemic, hopefully closer to the tail end, but you know, who knows with the mutations. Do you have any last piece of advice for us navigating through this weird time?
Whew, that was like the toughest question of the whole day. Oh my God. You know, it's hard. I don't think none of us have ever been through this. None of us have ever done this. But I think the biggest thing is be very aware of, I talk about mindset a lot. I should probably like be a mindfulness coach or something like that. Talk about like, just, if you're feeling like shit, say it to somebody, tell somebody. If you're feeling great, awesome. Like go smile at someone 6 feet away from you. But if you're like, I don't know, I think the biggest thing is just remember that we are not alone. Make sure you have a support system. Make sure that you're talking with people, checking in with people. If you feel great that day, check in with someone who you're like, ooh, I haven't heard from her in a while, or I haven't seen her post for a while, or I haven't seen her on social media for a while. I wonder what's going on. You know, like if you're feeling funky, talk to someone about it and make sure that you're doing the things stress about the things you can control. That's the biggest thing I tell people. I go, if you can't control it, which I can't control if this virus mutates, so I just can't worry about it. I have to do the best that I can do, which is stay safe, social distance, wear my mask. You know, I got my vaccine, which I'm thankful for. So I think the biggest thing is just worry about what you can control. And if you can't control it, you don't get to stress about it. I think that's, for me, having that mindset, good Lord, I need to think of a new word. Having that idea in my head has really helped me just to get through a lot of this, and knowing that there's no one's an expert on this. No one has any idea what they're doing. We are all just trying to survive this. No one's really thriving in this. It's just surviving. And if you have that mindset, I think that that's the biggest thing that doesn't set you up for failure. If you're like, I should be doing this and this and this during the pandemic, it's like, okay, chill out, calm down. Let's like focus on one thing at a time and let's do it really well. And maybe we don't have to do 78 things. So this is a very rambling answer because this question was really hard for me to answer. But I would just say, like, continue to do the things you can control, exercise, eat well, you know, talk with friends on Zoom, reach out to someone if you're not feeling great. And if you are feeling great, reach out to someone that you know might not be feeling great. So just be there for people.
Thank you so much. That was awesome. I think we definitely need to keep that in mind, to check on each other and keep each other accountable. Someone in the chat said that you sold them on Dio. So
yes!
That was accomplished. I think that was a lot of people's sentiment throughout the night.
Oh my God, it's because we're so great, you guys. I'm telling you.
And I think if you open up the chat, or if you have it open, you can kind of see all the praise coming your way right now.
Oh, you guys are great. I'm so glad this was helpful, because I remember when I was a pre-med student, I had no idea what I was doing. So I would have like killed to have doctors talk. So what you guys are doing is so great. So if you ever want me to come back, I would love to help out in any way that I can.
Yeah, we would love to have you back. Absolutely. And people are saying yes in the chat. So yeah,
yay! It's like social acceptance. I feel like the populace hit all over. It's like so exciting. I've never felt that way before.
I don't believe that.
And we hope that you.
I'm gonna show you like a high school photo of me. It's not cute. Not good.
But yeah, thank you so much. We definitely had so much fun.
Thank you guys so much for having me. This was fabulous. You guys are doing amazing things. So please keep doing everything you're doing. This is so great for people.
Thank you.
Okay, have a great rest of your night, and we'll talk to you soon.
Bye, guys.
Bye, Dr. Culver.
Thank you.